There have been 2 clinical trials that have been now published in the last year that have relatively convincingly demonstrated at these early time points that there's overall no survival benefit to completion lymph node dissection for the patients who were enrolled in those trials when comparing patients who had completion lymph node dissection to observation only. And so with an active surveillance program and close follow-up, it's likely that one of the tenets of addressing the regional lymph node basin in the first place, and that is regional control and staging, we could obtain the information that we need from staging from the sentinel node biopsy information and from the clinical and pathological factors associated with the patient. And from the standpoint of regional control, we've learned from these studies that failure of the regional nodal basin as a sole site of recurrence, where we might actually need to operate, as opposed to regional recurrence in the setting of distant disease, is much less common as a sole site than it is in combination. And so, recognizing now that we have better effective therapies that are moving into the adjuvant setting, we could begin to change the paradigm now of surgery always for these patients who have positive sentinel nodes, and now use the data that we have where we could use other tools for staging as molecular endpoints and other clinical pathological factors can replace some of the important staging information from the completion lymph node dissection, and recognize that we could address regional control issues and provide a less morbid approach to surgical management of patients with melanoma, since we also know that completion lymph node dissection is associated with significantly more morbidity than patients who have sentinel node biopsy alone, and therefore take a very selective approach to completion lymph node dissection.